Welcome everybody to attend our webinar today. I'm Dr. Dah-Ching Ding from Marlyn T Hospital, Taiwan. Is today's chair, and I'm co-chair with Professor Marlyn T. Today's webinar is the episode 4, talking about adenomyosis and the fertility and the consensus on HIFU treatment. So first, I will introduce Professor Marlyn. Professor Marlyn is a University of St. Thomas, UST faculty and medicine surgery. She's a master in health professions education. He's a head of reproductive endocrinology and gynecology endoscopy UST hospital. Now she is president of Philippine OBGYN Society. And she was past president of Philippine Society of reproductive medicine. She was also fellow in Philippine Society of Reproductive Medicine, Gynecology Endoscope, and ultrasound in OBGYN. So, Professor Marlyn, it's your turn.
Yes. Thank you, Dr. Ding, for that kind introduction. Hello, everyone. Greetings from the Philippines. Let me proceed with the introduction of the chair of this session, Dr. Dah-Ching Ding. Dr. Ding is the professor, Department of Medicine, and the Associate Dean of the College of Medicine of Tzu-Chi University. He holds the position of Director, Department of Medical Research, and the Director, Department of Obstetrics and Gynecology at Hualien Tzu-Chi Hospital. He is a board member of the Republic of China Society of Gynecologic Oncology and a board member of the Taiwan Association of Minimally Invasive Gynecology. Dr. Ding, my pleasure to work with you.
Thank you.
Now I know that everybody is excited to listen to the consensus on HIFU treatment on adenomyosis and fertility. And with that, it is my pleasure to introduce Professor David Cranston, who will give the opening remarks. Professor Cranston is the president of the International Society of Minimally Invasive and Virtual Surgery, a consultant urological surgeon, Oxford University Hospitals, NHS Foundation Trust, associate professor of surgery in the Nuffied Department of Surgical Science, University of Oxford, and the governing body fellow of the Green Templeton College, Oxford. May I turn the virtual floor to you, Professor Cranston.
Well, it's a great pleasure to welcome you to this HIFU series webinars, which is between APAGE and the International Society for Minimally Invasive and Virtual Surgery, looking at adenomyosis and fertility with a consensus on HIFU treatment. In Oxford, we have had the opportunity of treating a number of patients with fibroids, but certainly I am aware, and certainly more recently discussing it with some of my senior gynecological colleagues, of the importance of HIFU for adenomyosis, where often there's very little other treatment to be offered. And I think it's very important just to get a very good understanding of the role of HIFU in this. As the president of the International Society for Minimally Invasive and Virtual Surgery, just like APAGE, we've been very much affected by the COVID pandemic, which has restricted travel and personal attendance at conferences, although a lot has been done through virtual online technology. I'm certainly looking forward to the time when I can join you in person, because I think it's important that the personal communication does add more than just the simple online technology. Nevertheless, during the COVID pandemic, we have understood how important virtual and online technology is. like APAGE, the International Society for Minimally Invasive and Virtual Surgery, has not been inactive over the past year, despite the pandemic. And we've had a number of online conferences attracting nearly 8,000 participants. And quite a lot of members are now registered with us, joining you for some of these sessions, I hope, given the fact that I have one or two other things already planned. But I certainly look forward to hearing the results of this symposium. And I look forward to joining and with you to promote high-intensity focused ultrasound internationally. So thank you, and I wish you the very best for this meeting.
Thank you, Professor Cranston. May I now turn the virtual floor to Dr. Ding.
Okay. First, I thank Professor Cranston for opening remarks. Now, I introduce today our first speaker, Professor Rudy Leon De Wilde. I introduced Professor Rudy. He is a teaching appointment at the University in Munster. He is the medical director of clinical OBGYN and gynecology oncology at the Press Clinic Oldenburg. He is the head of University Clinical OBGYN and Faculty of Medicine and Health Science, Carbon Ossietzky University. She is also a full professor of OBGYN, University of Oldenburg, Germany. She is the Chief Medical Officer of Price Hospital, University of Medicine, Oldenburg, Germany. Today, he will give us a talk, should HIFU be considered as alternative non-surgical treatment of adenomyosis in non-Asiatic countries? Please, Professor Wilde. Let's welcome
Thank you very much.
Yeah.
Thank you very much, Dr. Ding. Thank you very much, Professor D. Thank you very much, David, for this kind introduction. So today we are talking about adenomyosis. And I am very thankful to have the opportunity to talk to you about adenomyosis, because adenomyosis is a big problem in gynecology. Let's start with my presentation. So, the question is, can you hear me?
Yes, we can hear.
Perfect. So, adenomyosis is a big problem because adenomyosis is a disease of the uterine wall and of the complete uterine wall. Very seldom adenomyosis, which is endometriosis of the uterine wall, is isolated in a small part of the uterine wall. Nearly always there is a diffuse adenomyotic tissue in the uterine wall. And very often those patients have not only hypermenorrhea, dysmenorrhea, and bleeding disorders, but they also have severe pain and they want to get pregnant. So all the surgical possibilities that we have until now are taking out the womb, doing an hysterectomy, or performing a very difficult surgical technique, namely cutting the uterus in many pieces and putting it together again as a reconstructive surgery. During the years that have passed, we can see that we are going from great trauma in open surgery, going to more minimal invasive surgery. So the normal question that is arising right now is, in case of adenomyosis, can we start looking at a disease which could be possibly treated by something more small than an hysterectomy, which is obviously not possible in case of people who want to get pregnant? Or in cases that we conserve the uterus, could we try to avoid major surgery, cutting the uterus in many pieces and putting it together afterwards? Yes. So, you all know how conventional surgery is looking like. You all know how laparoscopic procedures look like. The question that we have to answer and should make a planning for the future is HIFU possibly a solution for adenomyosis? We all know how HIFU works. We are putting in some kind of energy, namely ultrasound energy, under ultrasound guidance into the uterus. It is focused. This means the energy starts on a broad spectrum outside of the body and goes to a special point into the body. We all know that we can do an MRI to exactly differentiate the tissue that we want to target by our focused ultrasound. But there are many techniques right now that are using real-time diagnostic ultrasound to guide the energy, the high frequency energy ultrasound to the point that we want to reach, where we want to put our energy. The energy is put at small focus of 1 to 3 millimeter. This focus can be achieved by transforming, by using the transducer and by focusing the waves onto the spot that has to be reached. And this is, of course, something that seems very important in case of adenomyosis, because we can try to save as much of myometrium as we can to keep the circumference, to keep the whole of the body of the uterus in a good shape, to have the possibility to have a pregnancy in future. We all know that you can target those small spots and you can visualize them by using ultrasound. There is a change in gray color. There's a change in the color of the ultrasound, of the diagnostic ultrasound, when the target is reached, when the power spots are applied. So at the same time, when you are performing your high energy, when you are putting your foci, you can see in the real-time ultrasound that you reached your target, and you can modify to conserve enough myometrium going to the serosa to be sure that there is no defect in the circumference of the uterus, to make sure that later a pregnancy can be carried out. The gray changes, the gray scale changes can be visualized during the whole of the application of the high energy. The MRI is only put into your computer as an extra security, because you can follow your surgery the whole time by doing the ultrasound by yourself. So the whole of the surgery can be done by the ultrasound specialist together or in one person with the surgeon. The patients only need sedation, and this is important because we will talk about possible complications later on. Here you see a case of adenomyosis, and you see how the adenomyosis is targeted, is reached, and can be focused, especially on the diseased tissue, keeping the circumference, keeping the neighborhood of the normal myometrium intact, to reserve, to pre-reserve a functional uterus. And of course, if people are starting or not so, haven't got a high expertise, there is always help coming from people that have high experience, and especially in the Asian countries, there is high experience in applying HIFU for diseases of the uterine wall. Well, minimal invasive surgery is already a big profit and a big benefit for the patients. Doing minimal access surgery, even without cutting, will conserve all the possibilities that we have resecting or ablating or destroying the adenomyotic tissue, and thereby even omitting all scars that are possibly necessary when doing minimal invasive surgery. 3/4 of all adenomyotic surgery right now is done open. So the jump would be from open surgery without going to minimal invasive surgery into the HIFU. This would be a double jump and a double benefit for the patient. There are, of course, many possibilities where we can use HIFU in cases of gynecology, in gynecological disease. But we think that especially in adenomyosis, this is a system, a technique for the future, because in adenomyosis, there is not really a good surgical technique or a conserving, uterus conserving technique, or a technique that makes sure that afterwards the people can still get pregnant. If the surgery is done, and the surgery, I mean the ablation by HIFU, you can see afterwards that there is, of course, still a remnant. The remnant is not the adenomyotic tissue, because this tissue has been destroyed. It is the destroyed tissue that can still be seen. And during the weeks and months after the HIFU ablation, this remnant, this residual tissue goes away. Perhaps it doesn't go away completely, but at the end, what we want is not that the disease or that what we see disappears completely. What we want is that the problems of the patients, the complaints of the patients go away. And this means the bleeding disorders, the pains are going away, and she still has the possibility to get pregnant. So at the end, there is some remnant to be seen, but this goes away over the years, over the months to come. And it is really true, the dysmenorrhea is going away, it disappears. Eventually, not completely, but it is diminished, and some people say it is completely gone. Also, the menstrual volume, the residual volume is going down. In cases of adenomyosis, there are some studies. Well, there are not studies on 10,000 patients. In the Asian countries, there are more than 100,000 patients that have already been treated with HIFU. But in cases of adenomyosis, looking at the pregnancies, those major studies are not there yet. But the studies that we have are very promising and are showing that after a therapy of diffuse adenomyosis, pregnancies are possible. And not only pregnancies, but healthy babies delivered. Take baby home rate. There is no technique without complications, so there is always some risk. The risk is there when you do open surgery. The risk is there when you do minimal invasive surgery. In case of HIFU, if you have a lot of fat in the abdomen, there can be a problem. There is some trick that you can use with a pad, but still there can be some problem due to the heat accumulation. Most of those problems resolve without any intervention afterwards. If the adenomyotic tissue is going into the cavity after it has been ablated, then of course there will be abnormal discharge through the vagina or an abnormal bleeding. But this of course only stays as long as the person is rejecting the tissue, is ejecting the tissue transvaginally. At the time where the whole of the ablated tissue has been ejected by the body, then eventually it stops by itself. In cases where the tissue is not coming out of the uterus, an hysteroscopic evacuation is still possible, leaving the intact myometrium of the uterus there. So as you can see in this contrast T1 tissue, T1 picture, you see that the myometrium surrounding the ablated adenomyotic tissue is completely intact. And this is what is absolutely necessary to have a high take baby home rate. Bowel perforation. In case of open surgery, we have bowel perforation. In case of minimal invasive surgery, we have bowel perforation. We also have this, especially in the learning curve of HIFU, but it is a very low frequency. And if you know this can happen, you can have an eye on it. The risk is very low, as you can see in this graphic. Pelvic pain, nausea, and thrombosis are very rare, very, very rare. The pelvic pain usually goes away by itself or by taking non-inflammatory drugs, anti-inflammatory drugs. The nausea itself, symptomatic drugs. The vein thrombosis is very seldom. If looking at the data that we already have, as said before, there are more than 100,000 patients treated in case of benign diseases of the uterine wall. So there is a high experience with the complications that are there, and they are quite low. Also in adenomyosis, there are a lot of patients already taken care of with good results. Concerning the pregnancy rates, major studies are still being done. Dear ladies and gentlemen, as we go from open surgery towards minimal access surgery, there is still the future to come. Standing at the same place and not moving is always bad, not only in life, also in gynecological surgery. So we should look beyond the horizons. Looking beyond the horizons means that in case of adenomyosis, we have a high complaint rate of the patients, and we have a lot of women who still want to become pregnant. If we bring all this together, then I am sure that in future, adenomyosis treatment by HIFU is qualified, giving patients, again, a chance to live without their complaints and having the possibility to get pregnant. And because of the good results we have of the Asian countries, we are now in the European Union looking for major studies to check this also for our European people. But concerning the data we have right now, the technique looks very promising. Dear presidents, dear chairman, dear ladies and gentlemen, thank you very much for your attention.
Thank you, Professor Wilde. I have an audience. I have questions. Yeah, Professor D have a question. Is the HIFU treatment done only in one sitting, or what is the recurrence rate in terms of symptoms? Will there be a uterine size amenable to HIFU?
Well, there is the possibility, of course, to do the therapy in one session, but this is absolutely not necessary. If you see that it could be beneficial for the patient to do your surgery or your HIFU treatment in more than one session, this is absolutely possible. So out of my point of view, when possible in one session, do it in one session, but if not possible or not feasible, or out of point of view of the gynecologist, not the right way to do it, you can do it in many sessions. There is absolutely nothing that speaks against this measurement.
Okay. The second question is, what is the recurrence rate? in terms of symptoms?
Well, of course, you are treating the uterus. You are not taking out the uterus. This means that after the HIFU treatment, there is recurrence because the uterus is still in place. But this is, of course, the same problem if you are doing a gynecological surgery in adenomyosis. As long as the uterus is in place, you can have a recurrence of the disease. As said before, even if there is a recurrence, you could do a repeat ablation with the HIFU. Doing a repeat surgery is very difficult. The first surgery is already very difficult. Doing a repeat surgery in case of adenomyosis is extremely difficult. So out of my point of view, recurrence, yes, because as long as you don't do the hysterectomy, you can have recurrence, but the recurrence is not higher as in cases of surgery, and you can do a repeat HIFU. This is, in cases of surgery, nearly impossible.
Okay. Another question is, what is the biggest uterine size that can be treated? Diffuse adenomyosis.
Well, this depends on the experience of the person who is doing the treatment. I am sure that when you are starting your treatment, you are not doing very big uteri. You are not doing them because it's not the technique, the HIFU technique. You have to be experienced. You have to have a teaching. You have to have a quality management. So at the beginning, you should start with, for example, myoma or with solitary adenomyosis. If you are more experienced, you can do the size is unimportant. You can do whatever size you want, eventually in more than one session, because the lady is sedated. The lady is not in narcosis. So somewhere in time, she will say, now I feel more pain or the heat is expanding. And then you stop your ablation. And eventually a few weeks later, you continue.
Okay. Their question is, how much of the adenomas is ablated in the initial treatment?
Yeah, this is the same answer. It is the experience of the person who is doing the HIFU and what the lady itself can bear. And this is different, depends on what she is accepting when she is in sedation. But as said before, this is not a major problem because you can repeat after a few weeks. And the question there is also what is in Europe? The HIFU is implemented in the NICE criteria, for example, in the UK. So this means that for parts of the Western world, it is already accepted as a standard treatment.
Okay. What is the take-home baby rate after adenomyosis of HIFU treatment?
Well, the take-home baby rate, as said before, major studies are not there. The studies that we have right now is 1 on 3. And 1 on 3 doesn't look so high, but 1 on 3 is extremely high if you compare it with people who have no treatment of adenomyosis or people that have surgical treatment of adenomyosis. So even if we would not find a higher frequency than 1 on 3, even try to answer the last question again.
Okay.
Even if the major studies are not showing a frequency of take baby home of more than 1 on 3, even then it would be a major success because not treating the patients has a very low rate of take baby home. And doing surgery is certainly lower than 1 on 3. So even if we don't go higher than the 1 on 3 that we have right now, it would already be a major success.
Okay. A lot of questions. Another question is, how soon after the first surgery can you do the repeat HIFU?
Well, the people who are doing the HIFU say it can be repeated immediately. But we think to leave 6 weeks between the sessions would be good, or even longer if the necrotic tissue hasn't come out or hasn't been resorbed or hasn't been retracted. So this is the case when you do an ultrasound, a diagnostic ultrasound control after the HIFU. You should have a look at what happens to the uterus and then decide. If, of course, you are doing, let's say, the front wall in the first session and the back wall in the next session, then there is, of course, no problem there.
Okay. The next question is, what is the current EU regulatory situation with HIFU? Where in Europe is HIFU being performed in routine clinical practice?
Yeah, this is what I just answered. In Western Europe, for example, in the UK, it is already adapted in the regulations, in the NICE guidelines. And this is, of course, important because the UK has a very high standard of medicine in Europe. Many other countries are already doing HIFU in Europe, but in Europe there is no common regulatory system. So every country in Europe has got to do their own impregnation of their guidelines, of their regulatory bodies. So this means that if you have 30 countries in Europe, you have to do this 30 times. So it will take a long time, not only for Europe to look in one direction, but also for all the European countries to implement HIFU in their regulations.
Okay. The next question, will it more difficult to ablate if the lesion is posterior than the anterior?
Yeah, of course, this is experience. This is experience. The smaller the adenomyosis, the more solitary the adenomyosis, and the better reachable it is, of course, easier to tackle. But the more difficult it becomes and the more diffuse it becomes, the more expertise you need to do the HIFU. This is a learning curve that you have to do.
Okay, the last question is there any difference between MRI focus and the HIFU regarding efficacy of treatment in adenomyosis?
So this means, is the question, is there a difference between MRI HIFU and the ultrasound HIFU? Is this the question?
Yeah.
Yeah, so there is, for me, one very big difference, that you don't need a radiologist when you do the ultrasound diagnostic and therapeutic. So out of my point of view, this is the very big difference between the both of them. Then we did a major study comparing the two treatment modalities, and most of the modalities are better with the ultrasound, but also the MRI focused is as a good result. It's not that this means this is a bad result, but most of the parameters we checked were in the benefit of the HIFU with ultrasound. Okay,
thank you. One more last question. Is there an age limit of performing the HIFU treatment?
No, there is not. But of course, normally you have no problems with your adenomyosis anymore if you are postmenopausal. So in case of the postmenopause and you don't take hormone replacement therapy, the adenomyosis will be sleeping soon. So in high age, normally you don't treat the adenomyosis anymore. So the focus that we have is diffuse adenomyosis, and this in patients who want to get pregnant, because for those patients right now, we really don't have a good therapeutic aspect. So HIFU is promising.
Okay, thank you, Professor Wilde. Thank you for your excellent speech. And thank you for your answer so many questions. Thank you.
Thank you, Dr. Ding. Thank you, Professor D. Thank you, David.
Okay. Professor D.
Thank you, Professor De Wilde, and thank you, Dr. Ding. Let me now introduce the second speaker, Dr. Sevelyaraha Supermanian. Dr. Selva is an OB/GYN consultant and a subspecialist in reproductive medicine at a private hospital in Melaka, Malaysia, where he also heads both the IVF Center and the HIFU Center. His initial training in laparoscopic surgery was under Professor Sung Kwei Yong and Dr. Lee Chi Leong at the Changgung Memorial Hospital, Taipei in 1994. He is a past president of APAGE and the Obstetrical and Gynecological Society of Malaysia, and is involved in promoting gynecological endoscopic surgery in Malaysia. He started the first HIFU center in Malaysia in 2021. With his experiences, he will speak on how HIFU can help with infertility secondary to adenomyosis. The floor is now yours, Dr. Selva.
Can you see my slide?
Yes.
Okay, thank you very much. I would like to thank APAGE as well, and also International Society of Minimally Invasive and Virtual Surgery for inviting me to give this lecture entitled Infertility with Adenomyosis, How Can HIFU Help? Now, before I start this lecture, let me say that I have been only doing HIFU for the last 1 year, maybe 13 months. I started in July last year. And my experience is not as great as many of the other surgeons probably in the world, especially those from China, those from Korea, and also those from Taiwan. The only difference is that I am also a fertility specialist. I've been doing IVF for the last 28 years. I'm also a laparoscopic surgeon. I've been doing that for the last 30 years. So with this experience, and now that I've started HIFU, I probably can give a different overview on how adenomyosis can help in infertility. So this is my disclosure. I run a HIFU, ultrasound-based HIFU center at Mahkota Medical Center, Malacca. Now, when we look at HIFU, there are different types of, when we look at adenomyosis, there are different types of adenomyosis. By ultrasound, we usually say adenomyosis is diffuse adenomyosis, or focal adenomyosis, or adenomyoma. And this is a very good book edited by my friend, Dr. Felix Wong. And this gives you a very good overview of adenomyosis. Now, if you look at ultrasound diagnosis of adenomyosis published in this Ultrasound in Obstetrics and Gynecology, there are actually many criteria. There's altogether 8 criteria. The criteria that we normally do is an asymmetric enlargement of the myometrium, the presence of small, what we call as cysts, hypoechoic islands, and also big islands, and also the others are the shadowing, blood supply, break of the junctional zone, blood inside the adenomyosis, and also break in the junctional zone. So these are different ways in which we make ultrasound diagnosis of adenomyosis. Now, if you look at MRI, the situation is much more different. We also what we call classify adenomyosis by calling them diffuse, internal adenomyosis, external adenomyosis, and adenomyoma. And here you can see different categories of adenomyosis in MRI. They are subdivided into internal adenomyosis, adenomyoma, and also external adenomyosis. And in the internal adenomyosis, there are A, B, C, D, and E. You can see there are minor ones and also major ones, which we classically call them as diffuse adenomyosis up to E. Then we have adenomyomas, which can present in different areas, for example, in the intramural area, in the submucosal area, and also in the subserosal area. Then, of course, the more difficult ones, which are the external adenomyosis, where you can have it in the posterior wall, infiltrating into the rectum, or anterior wall, infiltrating into the bladder. So we must understand that adenomyosis is actually a varied disease. And when it comes to HIFU, as I will describe later, treatment can be different and can be difficult. Now, when we look at adenomyosis, there are 2 different types of patients. The first group of patients are those with adenomyosis who do not want to conceive but still want to retain their uterus. The second one are those who want to conceive. And this is what we are going to look at today. I'm not going to talk about this part, which is actually the easy part of the surgery. Those with adenomyosis who want to conceive are the ones that gives us the biggest headache. So this is what I'm going to discuss today. Now, for those who want to conceive, what is the options we have now? We have adenomyomectomy, as what has been said by Professor Rudy. It is not an easy surgery. It's a very difficult surgery. I do it by laparoscopy, and I think the next speaker will be speaking on it. It's not very easy to do this surgery. And whenever I do this surgery, I always worry that if they get pregnant, whether I'm going to get a uterine rupture. The other option, what IVF specialists usually do is they give them GnRH analogs or Dynogest, and then hoping that they will have a shrinkage of the adenomyosis and the patient can have a spontaneous pregnancy. Or if they have frozen embryo, we do a frozen embryo transfer. This is what we have been doing all these years. Now, we know what HIFU is. It has been discussed by Professor Rudy. HIFU uses focused ultrasound beam to ablate adenomyosis. And we are using ultrasound beam to heat up the tissues in a focal point in the adenomyosis and cause the adenomyosis to die. So what are the advantages of ultrasound-based HIFU? Somebody asked this question. There are two types of HIFU machines available in the world. This is the MRI-based HIFU. This is the ultrasound-based HIFU. And in my mind, the advantage one is that ultrasound-based HIFU is actually real-time ultrasound imaging. We do it 1 second at a time, whereas in the MRI-based HIFU, it's not real-time. You actually have a time where the machine will be shooting the beam for 20 seconds where you've got no vision at all. So it's not real time. And also one of the other advantages, the transducers used during the ultrasound-based HIFU are larger and more powerful as opposed to that during the MRI-based HIFU. So we can give much bigger energy for a longer duration in ultrasound-based HIFU compared to the MRI-based HIFU. There's a better transducer movement during an ultrasound-based HIFU. If you look at the ultrasound-based HIFU, it can actually move 12 centimeters on either direction and front, back, up, and down, whereas the movement in the ultrasound-based HIFU is very minimal. And that is the reason why it is far more powerful than that of the MRI-based HIFU. Because of that, you can have a shorter operating time using the MRI-based HIFU as opposed to an ultrasound-based HIFU as opposed to the MRI-based HIFU. I think the most important thing is that because of all these advantages, there is a better success rate. You can get a higher non-perfusion volume after an ultrasound-based HIFU compared to an MRI-based HIFU. The biggest advantage of an MRI-based HIFU is that you can have temperature monitoring in the MRI-based HIFU as opposed to the ultrasound-based HIFU, and also the images are far better in an MRI-based HIFU than an ultrasound-based HIFU. But these are the advantages of an ultrasound-based HIFU. Now, what are the benefits of HIFU for an adenomyosis patient? It is non-invasive, as has been discussed. When shrinkage of adenomyosis occurs, the uterus will become smaller and it will be more amenable to pregnancy. This is what we are trying to achieve. There is a reduction in symptoms, namely menorrhagia and dysmenorrhea. The patient can start conceiving after about 4 months after treatment. When you see there's a shrinkage of the uterus, then the patient can start conceiving. And also the patient can even have a normal delivery after treatment because there's no scar in the uterus. And this is the big advantage compared to adenomyomectomy, where you have a big scar and we don't know what is going to happen. We definitely have to do a cesarean section, but we are worried that the patient may have a uterine rupture while she is pregnant. Now, this is my experience. My experience is not big, it's limited. It's about 13 months. And I have done 112 cases of adenomyosis, 140 cases of fibroid, and 17 cases of adenomyosis and fibroid, a total of 269 as of yesterday. And here, this is the first HIFU case that I was doing with my teacher, Dr. Huang, who is now in Changsha. It's nice for her to come down and spend 3 months with me to teach me how to perform HIFU. And now I perform HIFU on my own. This is the HIFU center in my hospital. It's a small room with this machine in it. And we do this surgery here in Makota Medical Center. Now, what are the principles of HIFU ablation? What is the difference between ablating a fibroid as opposed to ablating an adenomyosis? And this is important because there are two different things, and the way in which we do is also difficult and different. Now, when we see a fibroid, it's got a capsule. It's very well encapsulated. So when you give energy into it, this is a contrast MRI, and you can see that it's well encapsulated. So when we can give energy, the energy will be contained within the capsule, and you can maintain it. And you can see here, I've done this MRI-based HIFU. We can keep the energy within. This is another small fibroid. Now, this is not the same for adenomyosis. As you can see, an adenomyosis patient will have adenomyosis all over the uterus. If they're lucky, it's in one place. Like this patient has got an adenomyosis behind and also in front. and we must try and ablate as much as this disease as possible. And so the ablation is difficult and can be very frustrating and difficult, because we cannot get to every area of the adenomyosis. So this is far difficult and far different from that of fibroid. Now, what is the difference in performing HIFU for patients who want to conceive and not keen to conceive? There are two differences. It's a big difference between these two. Now, for a patient who do not want to conceive, we can do extensive ablation can be performed, and this can even include the endometrial cavity. The success rate of reducing symptoms is higher in this case. So if the patient doesn't want to get pregnant, I can ablate as much as I can, even involving the endometrial cavity, although we try to avoid that, and we can do that kind of ablation. And so the success rate of reducing menorrhagia and dysmenorrhea is far higher, as opposed to a patient who want to conceive. The ablation will need to be done more carefully to avoid ablating the endometrium. In this case, the ablation will be limited, and the success in reducing symptom will be lesser, as the energy will be given to the adenomyotic area. So this is very important, because when we are doing adenomyosis in patients who do not want to get pregnant, it is different from that with the patient who want to get pregnant, because the amount of energy that we need to be given must be very controlled, so that if possible, we don't want to hit the endometrial cavity. So I always tell my patient that if you want to get pregnant, my ablation will not be so extensive, and your chances of the getting back the disease will be much higher than if you do not want to get pregnant. So what are the challenges in ablating adenomyosis? So not all adenomyosis cases are the same. I showed you all just now that there are different types of adenomyosis in different positions and different areas, and not all of them are the same. And in some cases, there is a gap between the adenomyosis and the endometrial cavity, so that there's a gap between the junctional zone and the adenomyosis. In these cases, the chances of reaching the endometrial cavity is lesser. In others, the adenomyosis reaches up to the endometrial cavity, breaching the transformation zone. Here, it is very easy to reach the endometrial cavity. So the energy must be low and very controlled, and this can be very difficult. Now, I always wonder whether endometrium that has already been involved by the adenomyosis, whether reaching the endometrium will be beneficial, as probably new endometrium will grow over the ablated endometrium. I've been taught that I shouldn't reach, but in many cases, so what if I reach the endometrium? If the endometrium has already been affected by the adenomyosis, if I ablate it, will it be better? Will it be actually better for the patient? Actually, nobody knows the answer to this question. I can give you an example here. This is a patient with adenomyosis. She has an adenomyosis that is from here right up to the endometrial cavity. You can see that it's bulging into the endometrial cavity. And when I did the ablation as carefully as I can, it still reached the endometrial cavity. Now, this patient wants to get pregnant. Will her pregnancy be affected? Actually, we don't know. Now, here I can show you another case. This is a case of a patient with adenomyosis. This adenomyosis is quite extensive. As you can see, it is involving all around the endometrium. And this is the MRI showing the adenomyosis. You can see that it is involving the front and the posterior part of the uterus. This is my treatment. And when I did the treatment, it was very difficult. She was 39 years old, the doctor, and she's not sure whether she wants to get pregnant, she may get married. And this is the ablation that I did. And you can see that even after how much I controlled, there was still an endometrial involvement. And this is the adenomyosis after 3 months. In 3 months, you can see that the ablation here has reached the endometrium, but not that much. And I was fortunate to do a hysteroscopy for her recently. And this is how the hysteroscopy looked. Just to give you an idea that I reached the endometrium, and the part of the endometrium was actually ablated. And here is how it looks. And you can see that this part of the endometrium is normal, you can see, and the top part is normal, but the lateral part, the right lateral part, there was some tissue that is necrotic tissue involved in showing that this part of the endometrium has been ablated. So this patient, actually, I removed all this necrotic tissue and then put in a Mirena, hoping that the adenomyosis will not recur. So the question to ask is, if you reach the endometrium, is that bad for the patient? can she get pregnant with this normal endometrium? And also, can this ablated endometrium regrow? In my mind, I think it will grow back, and she will probably, this patient will probably has a chance to get pregnant. So here in this lecture, I'm going to concentrate on different types of patients. When we look at adenomyosis patient, there are different types of adenomyosis patient. There are, of course, those who are not keen to get pregnant, and then there are the ones who are keen to get pregnant. And those who are keen to get pregnant, I divide them to 3 types. One is a patient who has frozen embryo, and the second is the patient who is still single, and the third patient is a patient who is keen on spontaneous pregnancy. And of course, there's one group of patients who is unsure whether she wants to conceive. These are the patients who are in the late 30s, who are single, and we don't know whether they, she wants to get pregnant, probably if she gets a partner. So in this particular lecture, what I'm going to do is I'm going to concentrate on these 2 groups of patients with a little bit on this patient who still want to get pregnant. So these are the patients that we see in our practice as IVF specialists, and also patients taking care of patients who want to get pregnant. So let's look at the first group, a patient who has frozen embryo. I like this group of patients because, as I will tell you, these patients are the best for the group who wants to get pregnant. Now, in this group of patients, we must ablate. The ablation need to be done very carefully to prevent involvement of the endometrium, as I showed earlier. And I usually give them GnRH analog for 3 months. And after 3 months, I plan that the embryo transfer should be done after 3 months of HIFU, irrespective of whether the patient has got her menses. Now, the reason why I'm doing this is, in the beginning, what I was doing is I was waiting for the patient to get their periods and then do the embryo transfer. And I realized that the time when the uterus is the smallest in size is at around 3 months, because that is a time when the effect of the GnRH is the maximum, and also the uterus has shrunk to the smallest size. Although the adenomyosis has not, still is shrinking, but after that, what will happen is because the GnRH analog wears off, the uterus becomes larger. I'll show an example of a patient later. So in my mind, this is the best time to do the embryo transfer instead of waiting for the periods and then do the embryo transfer. Now, I'll give you all an example. This is a case study. This lady is Madam CLF, a 35-year-old lady married for 5 years with no children. She underwent an IVF in 2019, and she had 2 frozen embryos. She was given 1 dose of GnRH analogs after this frozen embryo depot, which is a 3 months one. In 2020, she underwent a laparoscopy, and she was given again another GnRH analog. This one is monthly for 2 months. Now, after that, they did an embryo transfer in June 2021. She did not conceive. Now, she was referred to me, and she complained of severe dysmenorrhea and heavy menses. She was on tranexamic acid to control the bleeding. Now, when I saw her, her uterus was 16-week size, and ultrasound showed a large posterior adenomyosis, and the size was 9.63 times 10.84 times 8.656 centimeters. And this is how the adenomyosis looked. This is the adenomyosis, and this is the MRI showing the adenomyosis. And you can see that it was an enormous adenomyosis involving most part of the uterus. And this is the transverse scan. This is the right side, and this is the left side. You can see that the adenomyosis is actually bulging into the endometrial cavity. And this is how the MRI looked. It's a large adenomyosis bulging into the endometrial cavity. So we did the HIFU. I did the HIFU with my teacher, Dr. Huang, and she underwent HIFU in September 2nd, 2021. And this was those who do HIFU will probably understand this. We used a maximum of 400 watts, and the average was 400 watts. The duration of the surgery was 143 seconds. We sonicated for 1,635. This is generally considered quite a long surgery. Sonication elapsed time was 668. We used a total energy of 654,000 joules of energy. Estimated volume was 5.55, and this is we used 400 watts for all the ablation. So this was the uterus at the end of 3 months. I didn't do the MRI immediately after the surgery for this patient, and this after 3 months, and this is how it looked. it was okay. I think we actually reached the endometrial cavity. We couldn't have not reached the endometrial cavity. And this is the transverse view of the finding. You can see that the endometrium, we have actually reached the endometrial cavity. So this is the MRI of the patient. The volume of the uterus before surgery, it's on the 17th of August 2021, was 940 centimeter cube. After about 1.5 months, it came down to 448 centimeter cube. And you must remember that after the procedure, we actually gave her 3 months generation logs. And at about 3 months later, the volume was 318.6 centimeter cube. And at around 6 months, it was 265. This one of the earlier cases that I actually waited for 6 months. It was 265. So the volume reduction of the uterus, not the adenomyosis of the uterus, was 71.8% volume reduction. So it's a very successful surgery. And I am very sure that I didn't do a hysteroscopy on her before or after the ablation. And I'm quite sure that part of the endometrium must be ablated in this patient. So I sent her back to a IVF specialist for frozen embryo transfer. The IVF specialist actually repeated a CA125 and found that it was high. It was 76.6. So she gave her another course of generation analog for 3 months. And the CA125 after 2 months reduced to 20.7 international unit after 2 months. And then she did an embryo transfer without inducing any bleeding. She gave Proginova 2 milligrams 3 times a day for 11 days. And then she added utrogestin and did the frozen embryo transfer on the 25th of June, just recently, 2022. And she just informed me the patient is currently 9 weeks pregnant. So this is my second case of pregnancy after HIFU for adenomyosis. The first case is this one. Before HIFU, another huge uterus, about almost 18 weeks size, both anterior and posterior. I did the ablation again. I must have reached the endometrial cavity. And this was at 3 months, the uterus shrunk. And this actually at 2 months. And I immediately sent her to my friend to do the frozen embryo transfer. He actually did the frozen embryo transfer. The patient actually conceived, but unfortunately she miscarried. So he has given her another generation lock and he's going to do a frozen embryo transfer soon. So the in HIFU patient with frozen embryo transfer, the difficulty in these patients is to decide when is the best time to do the frozen embryo transfer. I am giving generation depot, which lasts for 3 months after HIFU for my adenomyosis cases. The reason is that in my country, we include this into the insurance, and so it's paid by insurance. I know in China, my teacher tells me that they give monthly generation log. So in my limited experience, the shrinkage of adenomyosis after HIFU and at 3 months, the generation is the maximum, and at the 3 months post HIFU. So when we do HIFU treatment for adenomyosis, and then we give the 3 months generation analog, the maximum effect, the smallest size, is actually at around 3 months. And that's the reason why I'm making the suggestion that after the uterus expand, after 3 months, the uterus will expand due to the varying effect of the generation analog, and spontaneous menses usually occurs at 4 to 6 months after the generation analog. So currently, I'm advising all my patients frozen embryo transfer at 3 months post HIFU, even before the return of menstruation. So this is what I have been now suggesting to my patient. So now let's look at the second group of patients, which is the patient who are still single. Now, these patients, we also need to do careful ablation without involvement of the endometrium. I also give them generation analog for 3 months. And then I ask the patients to take one of the followings, either Mirena, Dynogest, Depo-Provera injection, continuous oral contraceptive pills, or Implanon. My favorite is Mirena, but many of these patients are single, do not want, and they are Virgo intacta, they may not want Mirena. So we will give them Dynogest. Depo-Provera is not something I like because it's very profound effect. Continuous oral contraceptive is another example. Implanon, I've never tried, but I think this is another option. But it is important for them to take one of these because what Dr. Rudy said, however much we ablate the adenomyosis, I told you we can't do 100% of the adenomyosis. We may do 60, maybe 70% if we are lucky. Whatever remaining is going to come back. So we need to suppress those from coming back by giving this medication until the patient wants to get pregnant. So I'll give you an example of a girl that this is a 23-year-old lady with a severe adenomyosis, and the whole posterior wall was involved and even the anterior wall. We did an ablation for her. This is the MRI after 1 day. Okay, decent, and ablation, not fantastic. And this is 3 months later. It has shrunk very nicely. And this is my ultrasound findings. This is before HIFU, the volume was 382.78 centimeter cubes. This was 3 months after the HIFU, it was 212.35. And then she disappeared. She didn't take any medication. She didn't come back. And 10 months later, and the reduction here is 44.5%. And 10 months later, when she came back, the volume has increased to 330, almost close to this, maybe only about 20% reduction. So this has made me learn a lesson that we need to be very careful and counsel the patient that after the 3 months, they have to take some kind of treatment so that the adenomyosis doesn't recur. Now let me look at this group of patients, which I don't like, the patient who is keen on spontaneous pregnancy. So here also, we need to be very careful in the ablation without involvement of the endometrium. And I give them GnRH analog for 3 months. If it is unable to conceive within 3 months, I strongly consider them as assisted conception. Now, many of these patients have been married for many years and wanting to get pregnant on their own. But if they don't conceive, then I will seriously have to talk to them that if you do not do anything about it, you will get your adenomyosis back. So you got to consider assisted reproductive technique. So here's an example of a patient. This patient has got a large adenomyosis. It was 13 centimeters by 7 centimeters, the whole uterus. I did ablation for her. I did a fairly good job. I thought this is an anterior adenomyosis. Anterior adenomyosis are easier to do than posterior adenomyosis. There was a question just now because it is more easily amenable and we can control the ablation, and the chances of it involving the endometrium is also lesser. This 1 day after the HIFU, and this is 3 months after the HIFU. The uterus has shrunk, the adenomyosis looks very good, but I am worried for her. She wants to get pregnant on her own. I said, you go and try. If you cannot, by 6 months, I think you should do IVF. So this is that same patient. Before HIFU, her volume of the uterus was 396 centimeter cube. 3 months, it was 178, a reduction of 55%. I'm telling you, this is not the adenomyosis, but the whole uterus. There's a reduction of 55%. So I'm keeping my fingers crossed that she will get pregnant on her own. If not, we will probably have to advise her to do IVF. So in conclusion, adenomyosis is a very difficult problem. I think all of us know if you have a patient with adenomyosis, especially if the adenomyosis is large, it is a very difficult problem. It's more difficult when the patient wants to conceive. Studies have shown that success rate in reducing menorrhagia and dysmenorrhea is up to 85%. Not all adenomyosis cases are the same. In some, ablation is easy. In others, it can be very difficult. In women with adenomyosis who have difficulty in conceiving, especially after failed IVF, HIFU is a good option to shrink the adenomyosis before frozen embryo transfer. I've given you 2 examples. This is from my limited experience for the last 1 year. There are many challenges in performing HIFU for these patients, including how much to ablate and how to avoid the endometrium. In many patients, even however I control the ablation, I still hit the endometrium. And I think in my mind, it doesn't matter if you hit the endometrium. The next difficulty is to decide when is the best time to do the frozen embryo transfer. I am suggesting that it should be done at 3 months post-HIFU. I've also learned from my colleague that we can use CA125 to decide whether we can do embryo transfer. So now routinely I do the CA125 before I do ablation, and then just before transfer we do a CA125 again. And when the CA125 reach normal value, then it's a good time to do an embryo transfer. There's no necessity to wait for the next periods. HIFU can also be done in patients who have adenomyosis who want to conceive spontaneously, but she must be prepared to repeat the HIFU treatment if she did not conceive and the adenomyosis recurs. This is something that I keep repeating, telling my patients that if you don't get pregnant fast, it will come back and I have to repeat the treatment. And I also tell them that you have to consider IVF earlier in these patients. Thank you very much.
Thank you, Dr. Selva, for that extensive lecture. The floor now is open for questions. Let me see the chat box. The first question is from Dr. Silaw. Dr. Selva, have you encountered fistula formation as a complication?
I don't understand fistula. Fistula from where to where? If you are looking at whether there will be fistulation from the endometrium to the skin, it is possible. It is possible. It has been reported. But other problem is bowel injury, of course, that Dr. Rudy has said. So I don't understand from where the fistula formation. Is it from the adenomyosis to the endometrium? Yes, there will be some kind of fistula there, because the adenomyosis, when it involves the endometrium, the disease from the adenomyosis will just, as what Dr. Rudy said, will fall off into the endometrial cavity and come out through the cervix.
Okay, thank you. Just a follow-up questions regarding the involvement of the endometrium. If you have done extensive ablation in a patient who is not desirous of getting pregnant, are there reported cases of a patient becoming amenorrheic?
Currently, I have not read about it, but I think technically it's possible. So the teaching from the company that makes it, which is for Chongqing Haifu, is try to avoid ablating the endometrium. We try our best to avoid. But in my mind, that will be a good thing. In fact, if a patient doesn't want to get pregnant, if you do extensive ablation and the whole endometrium is ablated, then you, for the patient not getting pregnant is a good thing. But I do not have data to say that this is something that commonly happens.
Okay, thank you. Another question. Why is the recurrence of adenomyosis very fast after HIFU?
Okay, as I said earlier, adenomyosis, when we do ablation of any structure, for example, the fibroid or an adenomyosis, we have to have a safety margin. And the safety margin is given to be about 15 millimeters to 20 millimeters from the serosa and from the endometrium. So you can understand that the endometrium, that the adenomyosis that we are ablating is within the adenomyotic area. So there will be a layer of adenomyosis that is all around the adenomyosis. So you will definitely have adenomyosis left in the uterus, whether you like it or not. So that's the reason why I'm trying to emphasize that when we do treatment for patients who want to conceive and those patients who do not want to conceive, it is different. We can give more energy to a patient who do not want to conceive to ablate more tissues. So when you ablate more tissues, whatever that is left behind will be lesser and the chances of it recurring will be lesser. Whereas if you are doing on somebody who want to get pregnant, you don't want to ablate too much because you're worried that it will involve the endometrium. Of course, you want to involve the serosa because the bowel may be stuck to the serosa. You don't want to burn the bowel. So that is the reason why it recurs. How fast it recurs will depend on the experience of the doctor and the amount the patient ablate, and of course the type of patient. That's the reason why recurrence rate is there. So if you don't want recurrence to occur, then you have to give medical treatment after the adenomyosis ablation. That's what I'm trying to emphasize. So if the patient does not want to get pregnant, you do say 60% of the adenomyosis you have ablated, you put in a Mirena in, that Mirena will cause no bleeding, and hopefully the adenomyosis will take a longer time to recur. It will recur, but it will not be so fast. That is the advantage. So another advantage is when we give ablation, we are shrinking the uterus. So the Mirena will sit in the correct place. As opposed to a uterus that is 20 weeks size, you put the Mirena, is not going to sit there. So there's a bigger advantage. So you're shrinking the uterus, so the chances of the Mirena sitting there and working will be better. So that's probably the biggest advantage of HIFU for adenomyosis. So one must understand that treating adenomyosis is different from treating fibroid. If you kill 80% of the fibroid, if you have a non-perfusion volume of 80% of a fibroid, because it's within the capsule, the fibroid will die and shrink. It is not the same for adenomyosis. Adenomyosis is all over the place. You are only treating what is there. Whatever is you're not treated is going to grow back. And that is explanation for it.
Okay. Another question, if the patient don't conceive spontaneously after HIFU plus 3 months of GnRH and 6 months of home coitus, no, or spontaneous, wanting to have spontaneous pregnancy, would you repeat HIFU treatment before embryo transfer?
I will have to see how well the treatment has been given and how the patient's symptom is. Probably when you do CA125. So say a patient who wants to conceive a patient undergoes HIFU treatment, and we give the GnRH analog for 3 months, and then we wait for her menses to come, which will probably take 4, 5, 6 months later. And then she tries to get pregnant for 6 months and she didn't get pregnant. Then we have to look at the uterus, how it is looking. If it looks good, say it doesn't look enlarged, then probably we don't have to repeat the HIFU. If it doesn't, which I think that is what it's going to be, because it's going to grow back, then you probably have to do another HIFU treatment before you can do a frozen embryo transfer. So I think in my mind, the best patients are the patients who have undergone IVF and have done an embryo transfer and failed, and they come to you. So they have got no other choice. The patients who have not had an embryo transfer, I will always talk to them and see if the uterus is 20-week size or 16-week size. I think there's no question that we have to do HIFU. But the uterus is, say, 14-week size or 12-week size. There's a small focus of adenomyosis in the uterus. Then whether the patient should actually undergo HIFU before the frozen embryo transfer is questionable. I would prefer actually for them to do the embryo transfer and test to see whether they can get pregnant or not. If they cannot, then come for the HIFU. So I will talk to them to see whether it is necessary for them to do the HIFU treatment. So I'm not saying that every patient who have adenomyosis must have HIFU treatment. What I'm saying is that those who failed and those who have very big uteruses, they are very, very good for HIFU. But those who have smaller uteruses and very mild adenomyosis, I will not do HIFU for them.
Okay, thank you. Are there still many questions? Is the presence of necrotic tissue within the endometrial cavity a contraindication to embryo transfer?
I am not sure. I don't know the answer to this. So if the endometrial cavity has been involved, I would suggest that we do a hysteroscopy, clear it up, and then do the embryo transfer. Now, I don't know how many of you all have done hysteroscopy on an adenomyotic patient with the adenomyosis involving the cavity. Actually, I've done a few. I forgot to put it up. You can see that one wall of the uterus, especially the posterior wall, is filled with adenomyosis. Now, if it is already filled with adenomyosis, how can the patient still get pregnant? So if you have ablated it, it probably gives a better chance for her to conceive because the anterior wall is good for the treatment. So in my mind, we don't know the answer to these questions. I think we need studies, and we need maybe even case studies to understand this before we can answer this question.
I think the next question is related to the previous question. Do you do routinely perform diagnostic hysteroscopy after HIFU treatment for adenomyosis, and when?
I do not. Maybe I should. I should do a office hysteroscopy, or do a hysteroscopy before HIFU and then after HIFU to see how they are. I'm not doing them because many of my adenomyosis patients are actually Virgo intactas. They are single women with adenomyosis. The one who are what you call as pregnant. The ones who want to get pregnant, we will do the hysteroscopy, but it is added cost for the patient. So if they do not want to, we do not. But I think if you want to be scientific about it, then you should do should do a hysteroscopy before, and then after the HIFU, you should do after that, and then only do the embryo transfer. But we have not been doing that.
Okay, another question. Will you consider HIFU as first-line treatment for adenomyosis or fibroid distorting uterine cavity, or still trying IVF first? I think
that is a very good question. Let me look at fibroids first. Now, I have already done 2 cases like this. I've actually written a paper on this. The paper is intramural fibroid, non-cavity distorting intramural fibroid. Should you do what is the best option for this patient? There's enough study to say that if you have a 3-centimeter fibroid, it actually reduces pregnancy rate. It reduces pregnancy rate, and this has been well established. So what are we going to do with a don't say distorting, uterine distorting, but even non-distorting uterine, cavity distorting uterine fibroids? Now, I've seen this patient who has got 3 or 4-centimeter fibroids, and she has already done IVF. She has got embryos. She has done embryo transfer, and embryo transfer failed. So now I am in a dilemma as to whether to do a laparoscopic myomectomy on this patient, or should I do a HIFU to shrink the fibroid? So we discussed, and in my mind, I think HIFU will be a less, less invasive method to shrink this fibroid than to go and do a laparoscopic myomectomy where I have to make multiple cuts and take out the fibroid and suturing it back. So I have already done 2 patients, and I don't think this has ever been done or published. I think even in China, people are doing fibroids for the large fibroids to symptomatic treatment, not for infertility. But this is something that I'm looking at, that we could actually do this patients. I'm not talking about the huge fibroids that you actually have to do a myomectomy, but the smaller fibroids that is cavity distorting or mildly cavity distorting, then we can give the option of HIFU for these patients rather than doing a myomectomy for these patients. I hope I answered that question. As for adenomyosis, I will never say that HIFU is the first line option for an infertility patient with adenomyosis. What I will say is that if the patient has failed IVF treatment, she will be a good candidate, because I don't want her to turn around and say that my HIFU is the one that caused her not to get pregnant. So I would be very happy if they have failed everything and then they come to me, I do HIFU. But we also see patients who are young, say like the girl I showed you, a 23-year-old or 24-year-old with adenomyosis, and she's suffering from pain and menorrhagia. Will I do HIFU for her? Yes, I will do HIFU for her in the hope that later she will be able to get married and get pregnant. So I will not say that HIFU is the first line treatment for adenomyosis. What I will say is it's an option I'll give the patient. If I could treat it by medical treatment, I will do that. I will give her Dynogest, Depo-Provera injection, Mirena, whatever. And if she's still resistant to that treatment, then I will consider HIFU. I hope I answered that question. We don't want to use HIFU as first line. What we want to do is that for patients who are refractory, we will consider HIFU.
Okay, question from Dr. Ding. He said, what an inspired speech. I have 2 questions. The first question is about the timing of embryo transfer after HIFU. Why the size of adenomyosis matter rather than the regain of MC? Then the second question, let's say a patient with diffuse type adenomyosis get pregnant after HIFU. What is your recommendation for her way of delivery? Why is uterine rupture a concern for this kind of patient by home?
Okay, let me look. I have to look at the question again. I'm seeing it. What about timing? Okay, why does the size of adenomyosis matter rather than regain the, what is MC? Regain of MC, menstruation. Okay, in my mind, I think the size does matter. When we do ablation of adenomyosis, we are trying to kill the adenomyotic tissue. And also we want to shrink the uterus. In my mind, the larger the uterus, I don't have the evidence, larger the uterus, probably implantation rate will be lesser. I cannot give you evidence-based medicine for this. The smaller the size of the uterus, probably it will be probably there'll be a better chance of pregnancy. I am not sure whether that is a valid statement to make. I don't think anybody can tell you that. So that is the reason why I want the uterus to be as small as possible for embryo transfer, rather than making it grow back and then do the embryo transfer. So to give you a proper answer, I don't know whether that is the right thing to do. But in my mind, that probably is a better option than waiting for menstrual cycle when the uterus grows back and then put the embryo transfer. So let's say a patient with diffuse type adenomyosis get pregnancy after HIFU. What is your recommendation for a way of delivery? Why is uterine rupture a concern for this kind of patient? Yeah, in my mind, I think, I mean, there are enough evidence, there are enough studies, there are enough patients who have delivered normally, a patient who have undergone HIFU for adenomyosis. So because we are not disrupting the serosa, at least the serosa, probably the endometrium we would have disrupted, but the serosa, I think her chances of having a uterine rupture is not high. So she could deliver normally. And there are many patients who have delivered normally, but this is not randomized control trial, it's just case studies. And in fact, I didn't put up those case studies, but there are enough patients who have actually delivered normally. Okay, I think I've answered that question.
Okay. Because of the time constraints, Dr. Selva will just answer the questions, no, through the chat box.
Thank you very much.
Thank you, Dr. Selva. I will now turn the floor to Dr. Ding.
Okay, thank you. Thank you, Professor D. I will introduce the next speaker. It's Dr. Hsin-Hong Kuo. He is a worker at the Division of Gynecology Endoscope, Department of OBGYN, Chang'an Memorial Hospital, Linkou, Taiwan. He is also a Deputy Secretary General in APAGE, Taiwan Association of HIFU Therapy, and the Taiwan Association of Minimal Invasive Gynecology. His specialty is HIFU, advanced endoscope surgery like lace, nodes, and robotic. Today, he will give a talk, tips and tricks in laparoscopic adenomyomectomy. Let's welcome Dr. Kuo, please.
Hello, can everyone see this keynotes page?
Yes, yes, we can see.
Yeah. Okay. It's my honor to be invited to be the speaker to share some of my experience in the tips and tricks to doing the MIS adenomyomectomy in the patient group who want to have fertile. And I'm amazing that Professor Supermania just finished more than 260 cases in 1 year. Oh, it's really amazing. That's why he called Superman. Okay, it's a joke. Okay, because I doing the HIFU since 2019, maybe February, and in this 3 years, I performed about 200 cases, and about 1/3 of that is adenomyosis. So some of my topic is comparing these two tools, and I have 6 topics want to sharing with all audience with you guys. And the first is pathogenesis, second is classification, and the third is how to perform adenomyomectomy to have complete or partial resection. And the fourth is let's to review the literature. And and the next I want to share my experience. And in the final step, I want to comparing MIS with HIFU. Okay, in the first, there is 2 kinds of pathogenesis. The first one is invagination. Invagination is comes from the TIAR, the repeated tissue injury and the repairment in the endometrium and the myometrium interface. And then the endometriotic gland will go into this area, and that's called invagination. You can also image that there is some regurgitation of the menstruation, and there is some debris of the tissue. That's some precursor tissue of the endometrial gland. And after she regurgitates into the cul-de-sac, and they go back and invade an invagination into the myometrium. So another one is like metaplasia. Metaplasia is, you know, sometimes it's called adenomyoma, just isolated adenomyoma inside the myometrium. Okay. So there are 2 kinds of mechanism, and let's talk about the classification. There is a lot of classification, but despite of the sometimes we like to call it diffuse or focal type, I was rather want to say that there is another kind of subtype classification published by Professor Kishi in 2014. That's they have the subtype just according to the mechanism. So let's see the classification. There is a 4 type subtype. but because the fourth type is a mixed type, so I only want to focus on the first three types. The first one is the intrinsic type. That means the mechanism is from endometrial gland invagination into the myometrium. And because it's intrinsic type, it's not involving in the serosal area. So it's a healthy myometrium here. Another type is extrinsic type. That's from the regurgitation of the menstruation. And the debris of endometrium invade into the myometrium. And you can see there is the invasion evidence that the color here is black, and the healthy myometrium is along with the slide in the endometrium cavity. And it's a junction zone here. It's very clear junction zone. But for the intrinsic type, subtype, there is no junction zone. And the third type is intramural type. But in my personal experience, it's a rare case about the intramural type. Usually it's only from intrinsic and extrinsic type. Okay, so comparing with these two types, you can find that because it's comes from the TIAR, repeated injury and repairment. So there is a higher sensitivity, that's higher rate, that the gravity of this kind of patient is higher, and because they have also higher rates about the termination, because maybe secondary to it's a disease secondary to the injury of the curettage. And how we can see the extrinsic type, because you can see there is a very high rate involving the posterior wall, because it's from regurgitation of the menstruation, right? And because of regurg of the mens, so it's more higher risk to have the bilateral ovarian endometrioma and the cul-de-sac endometriosis. Almost everyone have cul-de-sac endometriosis and obliteration. But in this paper, the Professor Kishi didn't mention a very key feature about these type 2 adenomyoma, is that because it's from the regurg of endometriosis, regurg of menstruation, so it's usually have posterior wall adhesion. That's adhesion will grab the posterior wall and causing adhesion of that area and make endometrial lining curve. So we go back to the typical image. You see, for the subtype 2, usually it's got the curved endometrial lining. So it's a key feature that is a key feature indication for me to do the adenomyometry if I saw this picture, because I want to release the tension in the uterine cavity and make the implantation more success. Okay, so let's talk about can we do the complete resection or just we can do partial resection, because when we review the literature, there are two kinds of resection, complete and partial. But if you know the mechanism, you can know that all the resection is incomplete. Why? Because if it's from the intrinsic mechanism, and you want to leave the flap, right, after adenomyometry, you want to maybe 1 centimeter in the subendometrial area and 1 centimeter in subserosal area. And in the subtype 1, you definitely will leave some residue tissue in the subendometrial area. And as well, in the subtype 2, you will leave the unhealthy tissue in the serosal area, right? But remember that, and in my experience, I want to tell you that the area you want to exercise in this kind of adenomyoma is bigger, because after you do the full adhesiolysis, in this case, the tumor got budged and it's got bigger. So in fact, you need to resect more. So in my opinion, every case after I do the adhesiolysis for this kind of case, I will do an intraoperative ultrasound to check the real size after I do the adhesiolysis. Okay, so because we analyzed the mechanism and do the subtype classification by MRI, so some audience could doubt that whether we need to do preoperative MRI for all the case. In my opinion, we don't do that because MRI in Taiwan is quite expensive. So I only do the MRI for HIFU, and I won't do the MRI for MIS case. So how can we identify is intrinsic type or subtype? In my opinion, to do the surgery, the mechanism is not important, because we finally will leave some residue tissue. So whether it's intrinsic type or extrinsic type is not matter. So we just do the resection, and the resection then all try to do a near complete resection and repair the flap more than 2 to 3 centimeters. And in this flap, definitely we will have some residue tissue, and I assume it's just near complete resection. Okay, so in my current conclusion, I want to do a small conclusion till this page. I only do MRI survey for HIFU patient only, and I do ultrasound survey for all the case, for the general survey, for the case who just want to do MIS, for the patient who urge to fertile, and if adenomyoma is involving the posterior uterine wall, and I saw there is a curved endometrial axis, I prefer MIS adenomyomectomy than HIFU, because HIFU can release that tension, and if the patient wants to get pregnant, it's very important for her to get pregnancy. And for this kind of patient, I suggest to do an intraoperative ultrasound after you did a full additional lysis. It's very important. Okay, we go to see the review the literature. How can we to do a good adenomyomectomy in laparoscope? Okay, there's a literature from 2011 that is just have the transverse excision, and just like we did for myoma, and we open that and do enucleation of the adenomyoma, and we repair that. You see that she just wants to repair the myometrium to myometrium. But in my opinion, this kind of procedure is not enough. First of all, if I only exist one transverse incision, I can't see all the lesion very clearly, because there is a lot of adenomyoma tissue in the corner of the, for this kind of case, in the anterior part and posterior part, there's a lot of corner. If you just excite a transverse incision, it will have much more residue tissue. Another issue is that adenomyotic tissue is very fragile. So if you just repair and along with the myometrium, you want to repair myometrium to myometrium, usually it's got tear. So in my personal experience, from a traditional way to do a myoma, it's not good. It's not enough for a surgeon to do adenomyomectomy. Okay, so it's the procedure from the Professor Osada is a milestone to do a perfect surgery for adenomyomectomy. Professor Osada did a laparotomic approach. The key point of that approach is for this kind of patient, is an anterior wall adenomyoma. She will open the endometrium cavity and introduce the finger inside endometrium cavity, and to check where is the border of that, where is the border of corner, and to make the sub-endometrium lesion about 1 centimeter in depth, and to shape the adenomyotic tissue, and to leave the 1 centimeter, about 1 centimeter depth in the subserosal area, and make a flap, a 2-flap repair, right? And then she got another flap. So it's called triple flap method. For case with diffuse adenomyosis, she will open the endometrial cavity from above. So it's a fungus. So open that cavity, and she will introduce a finger to find where is the corner. It's the same manner in the focal type adenomyomectomy, but the key point is the same. They will introduce the finger inside the cavity and to find the border, and to leave enough thickness the flap, and then do the triple flap repair. And beside of that, be aware that this kind of case doing the laparotomic approach is very benefit for applying the tourniquet. So before any procedure, they perform the tourniquet and block all the vessels, so they can have the kind of a vascular surgery. So that's the difficult part. We did the same surgery in laparoscopic approach. Okay, so when we go further to the how to do a good laparoscopic adenomyometry, and we review the literature, and there is a literature published in 2006. It's called double flap method. So it's also make a transverse incision, but she got a very big incision, so they can flip up and to see where is a residue in the corner of the anterior parts, and make near complete resection. And after that, they anchor the flap into the subendometrium area and make it's a double flap kind of method. It's kind of like Professor Osada, but in the laparoscopic approach, it's hard to do the triple flap, right? So they do the double flap. Okay, you also can apply this method to the diffuse type adenomyosis. So they just open, after they applying some vasopressin like agents, and then open the make a longitudinal incision and kind of see the endometrium cavity, just like Professor Osada, and open that and resect almost all the cavity. You can see it's a longitudinal incision and excise all the anterior part adenomyoma, posterior part adenomyoma, and repair endometrium cavity, and then do double flap repair. Okay, but just like what I said before, that I prefer to have more a full exposure of the adenomyoma, and I have some experience for doing the adenomyoma in my style. So there is a publish for our team in the fertility and fertility in 2020, and I will show this video how to do adenomyosis, adenomyometry in my 4-pedal style. Okay, it's a 38-year-old female. She got progressive dysmenorrhea for 4 years. After some medication treatment is just failure, and the hemoglobin is about 9, CA125 is about 67, and it's an anterior adenomyoma, about 4 multiplied 7. So in this video, if you guys can hear the voice, I prefer everybody can hear the narration in this video.
During laparoscopy, the uterus was enlarged, globular, with a local bulge at the anterior wall. Before the surgery, terlipressin acetate 1 milligram in 5 milliliters of distilled water was injected to reduce blood loss. At the start of the surgery, the anterior bulge was identified, and the boundaries on the fundus and around the lateral corpus were marked. Our surgical strategy involved making a cruciferous incision from the anterior bulging site 3 times to achieve a depth of incision of approximately 3 centimeters, according to our preoperative evaluation. The margins of extent were chosen carefully to avoid damage to the ovarian tissue nearby, to maintain the patency of the fallopian tubes, the integrity of the bladder in the anterior boundary, and the integrity of the endometrium in the fundal region. As the adenomyotic lesion usually manifests as the high-density fibrotic-like tissue, repeated incision on the cruciferous wounds was needed to get a better exposure of the tumor for the subsequent tissue removal, which finally transformed the uterus into a blooming 4-petal flower. It's worth mentioning that compared with a vertical incision, a cruciferous wound achieves good exposure of the lateral sides and minimizes residual tissues. In the following step of excising the lesion, a 0.5 centimeter thickness of the serosal flap was created, mimicking a petal, and a 1 centimeter thickness of the myometrium was preserved at the subendometrial region. The adenomyoma was turned into the shape of a blooming 4-petal flower. Water was injected into the uterine cavity to confirm the integrity of the endometrium. Suture repair in the method introduced is different from that in traditional myomectomy, which is performed by
Okay, it's the concept that we want to emphasize to repair the wound, because from the traditional myomectomy, we repair the wound from we repaired it between myometrium and myometrium. But for the fragile adenomyotic tissue, if we want to have a well repair and we want to decrease the rate about the hematoma formation in the corner, we need to anchor the flap to the sub-anemometrium area. So there is not, if we resect near complete adenomyoma, there won't have the myometrium inside here. So only thing you can do is anchor the flap.
Introduced is different from that in traditional myomectomy, which is performed by approximation of myometrium to myometrium. Instead, our concept emphasizes repair by anchoring the serosal flap to the subendometrial tissue. The direction of repair was from lateral to center, with care taken to avoid dead space. After anchoring the flaps, the margin of the serosa was approximated by 1-0 V-lock with visible shrinkage of uterine size. The patency of bilateral fallopian tubes was documented. The surgical time was 75 minutes, blood loss was 200 milliliters, and the specimen weighed 92 grams. The surgery went well, and this patient was discharged 2 days after the surgery. She achieved obvious symptom relief, and image studies demonstrated no recurrence with adequate anterior wall myometrial thickness in a 33-month follow-up. In conclusion, the 4-petal method adenomyomectomy.
Okay, so I have some successful pregnancy case when I doing the 4-petal adenomyomectomy. The first one is a 36-year-old. It's not too young, but it's not too old. More than 40 is not. So she had G2P0 and married infertile for 4 years. She have some symptoms, and the adenomyoma involved the anterior wall is about 6.8 multiplied 4.2. And the semen analysis and HSG is not so normal, but it's just have the left tubal patency, and there is no anemic, but the CA125 is kind of elevated. She got pregnancy 5 months after the MIS surgery. So that's a picture when we're doing the 4-petal adenomyomectomy. After we excise, open that, there is a 1, 2, 3, 4 petal. Here, 1, 2, 3, 4, and we excise the lateral residue tissue, and we got repair of that. And the specimen is about 35 gram. And after the surgery, 6 months later, the thickness of the myometrium is around 2.9 centimeter. Another case is involving the posterior wall. Is a 31-year-old female. Is quite young, and it's got severe symptom. And the least tumor is about 5.7 multiplied 3.2. And you can see the endometrial axis is very curved. That means is classified in extrinsic types, subtype, adenomyosis. And usually it's got endometrioma and cul-de-sac endometriosis, right? There, yes, there is a left side endometrioma documented in an ultrasound image. And the CA125 is quite high. Okay, so in this case, before we're doing the adenomyomectomy, we will do full adhesiolysis. So after that, I can lift the uterus up and make a cruciferous, like a cross resection, and do all the myomectomy. And after I repair that and perform the enucleation of bilateral endometrioma and fulguration of all the pelvic endometriosis, I do adapt to be the anti-adhesial agents. After 6 months later, the posterior wall thickness is about 3 centimeters. It's quite thick enough. And after 2 years later, she texts me a picture about she got the baby. It's a female baby. Okay, how about how we can do the 4-petal adenomyomectomy for diffuse type adenomyosis? It's a quite old age patient, 43-year-old. She got severe symptoms and want to conceive due to remarriage. But because she got so anemic, she has been to the ER for the blood transfusion, and the CA-125 is quite high. But this case refused IVF. She just wants natural pregnancy. So we can see the ultrasound here is anterior wall and the posterior wall adenomyoma. It's all about 4 to 5 centimeters. Okay, when we do diffuse type adenomyosis, the best important thing is we need to do uterine artery ligation. And for a case who want to have fertility ability, we need to do temporal ligation. Before all the procedure, we did vasopressin injection, and I will identify the IP windows and do the some manner just like make a shoes tie. So after surgery, I can release this suture. So that's I call temporary uterine ligation. So I will cross below the uterine artery and make the shoes tie. This is a procedure kind of complicated because you need to take maybe 50 to 20 minutes to finish this procedure. But after that, you can see a vascular uterus. It's a pail, right? So you can use scissor to cut to make a cold knife resection. So I also use make a cruciferous cross resection from the bulge site of the anterior wall. And because it's maybe 4 centimeters, so I will exercise that 3 times to make a depth about 3 centimeters. I will leave 1 centimeter distance in the sub endometriotic area. After that, I will repeat the same manner in the 4 pedal method. I will resect the lesion and leave about 0.5 or 1 centimeter thickness in the subserosal area. Okay, after I create 4-petal blooming flower, then I will check the endometrial cavity, and then I will do the repair. So if you can do the uterine artery ligation or tourniquet well, then you can do the diffuse type adenomyosis. The specimen in this case is quite heavy. It's about 130 grams. After anterior wall resection, I will repair that from anchor the flap to the endometrial cavity. After that, I can lift the uterus up and found the posterior wall adenomyosis is still very big, about 5 centimeters multiply 7. So I will repeat the same procedure again. After that, repair. After repairment, I will check the bleeding and have a final inspection. The surgical time is about 210 minutes. The blood loss is just 100 milliliter. And then I remove the IP ligament tourniquets, remove the uterine artery tourniquets, and make the uterus gut pink again. Okay, because I anchored the suture to the subendometrium cavity, and definitely I will penetrate into the endometrium. So that's why there is some pattern blue leakage. After that surgery, I checked the ultrasound 6 months later. The thickness is quite okay because it's all about 2.9 or 2.9 in the anterior and the posterior wall. In my experience, more than 2 centimeters, 2 to 3 centimeters is a very good thickness to prevent the rupture. From the literature, if the the thickness is less than 0.7 centimeter, there are 2 cases in 45 cases got ruptured. So remember, definitely you need to have a thickness of the flap more than 1.5. And my suggestion is 2 to 3. How about the pregnancy rate in the 4-pedal method? I didn't have the answer because I didn't have too much cases. But according to the article published in 2019, is a systemic review article, that there are 2 kinds of excision. You see, partial excision and complete excision. And how about the total conception? For the partial excision of the adenomyosis, including laparotomic way and the laparoscopic way, the answer is about 50%. It's quite high, right? And for the complete excision for total conception rate is about just about 27%. Why? Because of age. So let's check the age. Okay, this case is from a patient, about 200 patient, and the average age is just 36. And the next one is 34. So in this young age group, the conception rate is quite high. So the consumption, the subtotal consumption rate for the partial excision is 50. And let's to check the another group. From the article published from Kwak in Korea, that's because the patient rate age is quite high. It's more than 40. It's about 42. So the rate is really low. So likely is a laparoscopic group, and a laparotomic group is less than 10%. But for another group published for the patient with young age, about, you see, it's around 37 to 38, is more than 50. So the consumption of rate got lower. It's just about 27. So what's the factor affecting the fertility rates after the adenomyomectomy? It's also an article published by the Professor Kishi. Professor Kishi divided the pregnant patient by 2 groups. It's a young group and it's a older group. You can see the young group has a very high clinical pregnancy rate, about 41%. And the patient more than 40 and to have the surgery, just 3.7% to got pregnancy. And it's the only one patient. The only one patient comes from IVF. And you can see the overall pregnancy person, just 6% got pregnancy. And there are 5 got miscarriage after they got pregnancy. So only 1 got saved and have the baby. So the miscarriage rate is really high. Even we do a perfect adenomyomectomy in the patient more than 40-year-old, the miscarriage rate is really high. And the only answer they can get pregnancy is IVF. Okay, and another issue they got statistic analysis is to talk about whether they have the history of IVF before. So if the patient among these cases, more than you see in the younger group is 75 cases, in the older group is 27 cases. Among this group, if they have IVF treatment and the clinical pregnancy rate got higher than the overall pregnancy rate, because if they try pregnancy and got failure and you do a surgery, the successful rate got higher. Okay, so there is also multivariable analysis for the guy who got a clinical pregnancy, and there are 3 kind of factor will affect the outcome. The one is age, that we talked about before. The second is the history of IVF treatment, that we talked about before. And the third one is a posterior involvement. And in my opinion, that's because secondary to the pressure inside the endometrial cavity. So whenever I see a curved endometriotic axis, I prefer to do adenomyomectomy rather than HIFU. Okay, that's whether we need to do MIS or HIFU for a person with adenomyosis. It's a 35-year-old patient, P0. She lived the state in USA. So she's just come to Taiwan, did a HIFU and go back. It's an adenomyoma 10 centimeter. She got infertility for 2 years. She got severe symptom, and she even got uterine tension 3 times in her life. And CA125 is quite high. And let's check the MRI image. So after the image rolling down, you can see it's a posterior wall adenomyosis, and it's extrinsic type, and it's a very big posterior adenomyosis, about 10 centimeters. So, okay, would you do HIFU or adenomyosis for this kind of case? Okay, let's think about that. But finally, the patient choose HIFU because although it's the extrinsic type posterior wall involvement, but the axis is not so curved. It's kind of straight. So I said, okay, let's try that. So in USA, she got the GnRHA 3 months before HIFU treatment, and then she got the HIFU. That's to see the NPA rate. The NPA is a non-perfusion area comparing the preoperative contrast HIFU and the postoperative contrast HIFU, and to check the volume. That's the original tumor comparing to the ablated tumor. So the volume is just about 80 centimeters. There is a lot of residue tissue here, right? Even there is a ablated tissue, there are some live tissue also in the middle of that area. It's not too much. So for the MIS viewpoints, it's just kind of partial resection of this adenomyoma. But the patient, the patient got pregnancy. After 3 months, post-op HIFU GnRHA agonist injection, and she got pregnancy about 18 months later. It's a natural pregnancy, and she got because during the examination when they got pregnancy, she got preeclampsia, and because it's a severe preeclampsia, so the doctor suggests her to have natural delivery in the gestational age of 33. The baby is 1,070 grams around, and she text me a picture about that because the obstetrician do the 4D ultrasound and say that, oh, this guy got smiling because he had a pillow. That pillow is an adenomyoma. So that's an interesting case that I sharing you guys. Here is my take-home message. First is that I do HIFU patient for the adenomyosis tissue have straight endometrium. If the patient got pregnancy, please choose this kind of patient. And you need to judge whether you can protect the endometrium and ablate, near complete ablate all the adenomyotic tissue. And finally, because a HIFU patient is very special group, this group only wants non-invasive. No, it's there is no wound surgery. So the patient's willing is very important. Even I say that, oh, it's curved endometrium, I suggest do MIS. Some guys only say, oh, I just want HIFU. Okay. So another issue is whenever I saw a curved endometrium, I do MIS adenomyomectomy. And here is the tips and tricks about MIS. There is a lot of strategy to decrease the bleeding. Preoperatively, we do GnRHA agonist injection. During the surgery, I will infusion the tranexamic acid, vasopress. I will inject the vasopressin and do a uterine artery ligation or tourniquet. And for the posterior wall involvement adenomyoma, please do full adhesive lysis. Don't leave some adhesion tissue in the lower sigmoid colon, and please just free them all and do an intraoperative ultrasound check and to check the real size after you did the lysis. And please do full exposure. You can do 4 pedal, 2 double flap. Is both of all the skill is fine. Just make a good exposure and to fulfill a near complete resection and to leave the flap thickness about 2 to 3 centimeter. And for the patient who wants to get pregnancy soon, so you can inject a GnRH agonist after the surgery because she got to take the uterus rest about 6 months. And so have this GnRH agonist treatment, she won't have menstruation bleeding. So there won't have endometriotic tissue bleed inside the residue tissue again. So she got, it's got better. But for patient who want to have a pregnancy years after, that means that there's a gap time between the surgery and the pregnancy. Please do the adjuvant hormonotherapy. For me, I prefer Mirena, like Professor Subramania, and I also assume that dinogestrel is very good agents. So any kind of oral pill is okay. And in our experience, a young age, lighter specimen, and she got a she got a history of IVF before, or she got a post-uterine wall involvement, you got a higher pregnancy rate after MIS adenomyomectomy. Thanks to everyone. Thanks for listening. Thank you.
Thank you, Dr. Guo, for your excellent speech. Due to time limit, I have a short questions. How do you identify the endometrial cavity once penetrated? Did you insert IUD to prevent adhesion?
Wait, I will see that. Insert IUD for prevent adhesion. That's a prevention of that's a question about prevention the intrauterine adhesion.
Yeah.
But what we perform is extracorporeal. It's not inside the uterine cavity. So for me to insert the Mirena is not for prevent adhesion. It's just to prevent the recurrence of the adenomyosis.
Okay. Dr. Hong have a question for you.
Yes.
Professor Osada achieved a suitable residual thickness of endometrium by finger sensation. How do you estimate or sense or measure the residual thickness to the endometrium in your 4-pedal method? And the second question is, a patient get pregnancy after adenomyomectomy in your style? Is the risk of uterine rupture at 3rd trimester?
Okay, for the first answer, that's because Osada is doing the laparotomic style, and they can insert the finger. I can insert my finger by using laparoscope. Okay, so don't think about insert the finger when you're doing laparoscope. So we need to estimate the depth of the endometriotic tissue before the surgery. For me, I use the ultrasonic image, and because like is the depth is a 4 centimeter, right? And the transverse diameter is about 7 centimeter, but it's fine. It's not important. So when we go in more than 4 centimeter, I go into the endometrial cavity. So I check the distance of my Caesar blade. It's about 1 centimeter. So after I check the middle points of that adenomyotic tissue, I will resect that the first bite. The first bite is 1 centimeter. So I use 3 bites. It's a calculator that I can measure the depth when how I excise the depth of this tumor. So I make 3 bites. That's 3 centimeters. So I leave 1 centimeter in a subendometriotic lesion. And after it's got open, right, like a flower, I will excite the subserosal tissue. And I just using the blade as the scale. Half of the blade is 0.5 centimeters. So I just make it a scale and to create about 1.5 centimeter distance, the flap. Okay, for the second question is, there is no rupture. And I prefer to, there is an article about the pregnancy strategy to attach the optimal obstetric strategy after adenomyomectomy from the Kwon in Korea. And she got some suggestion that please do CS cesarean section for all the case. And please do not do that surgery when the gestational age got too bigger. It's just make it got the borderline preterm age is the best strategy. Just like 36 gestational age, 37 gestational age is a good timing for delivering the baby. So that's a strategy. And if the patient got any kinds of feeling about uterine contraction, please inform her to go to the hospital to have the colysis agents. That's all.
Thank you very much. Thank you for your excellent speech. So we will close our session. The next slide. Yeah, please follow us for more events at our page. We have Facebook, Instagram, YouTube, and a web page. And open your webcam and have a smile. We'll take a picture for everyone. Yeah. Thank you very much. Okay. Thank you very much, and see you soon in the future. Thank you.
Thank you. Thank you, everyone.
Thank you, Dr. Chen, Dr. Kuo, Dr. Rudy De Wilde, and also thank you for the Dr. Silvers for excellent speech. Thank you for joining us. Thank you very much. Thank you.
Thank you.
Bye-bye.
Thank you, Dr. Lee.
Thank you. Bye.
Bye-bye. Bye-bye.
Thank you. Yeah. Also, thank you, Dr. Lee. Yes.
Okay.
Yes. Okay. See you. Bye-bye. See you
Bye-bye.
next time. Yes.